Just about on time.
Yes.
Okay. All right. So you'll be keyed up for the national anthem.
I am.
Okay. Good morning. Instead of the Pledge of Allegiance, which we normally start off with, we're going to be playing the national anthem, and then we'll be introducing our sponsors.
And veterans, we invite you to salute. Tonight we are led in the singing of our national anthem by Maurice Madavon.
Oh, sing, can you see by the dawn's early light what so bravely we hailed at the twilight's last gleaming, whose broad stripes in bright stars through the perilous fight, o'er the ramparts we watched were so gallantly streaming, and the rocket's red glare, the bombs bursting in air, gave proof through the night that our flag was still there. Oh, say does their star-spangled banner yet wave? Oh, the land of the free and the home of the brave.
That is a championship rendition of the national anthem, to be sure. Maurice Madavon with our Star Spangled Banner, as we're just about ready for Game 1 of the Atlantic League.
And thank you, Frank Bolton and the Long Island Ducks. I'm going to introduce who our sponsors are. You know, every year we have annual sponsors that help keep this program going. We have Lewis, Joes, Avalone, Aviles. That's a formidable law firm. And we have Toomey, Latham, Shea, Kelly Dubin, and Quantarero, also a very prominent law firm on Long Island. And we have Gershow Recycling and Covanta Energy. I want to thank them all. Today's sponsor is Public Relations Marketing Group. I don't think they have a representative to speak on their behalf right now, but they are the company that we use in conjunction with Limba. After the presentation of our guest, Kevin Dahill, we will have a Q&A period, and we may have a Q&A period in the course of his speech too, but you will be able to raise your hand by pressing Alt Y on your keyboard, and that will let us, our technical people, know that you want to make a question. So we're going to begin. I'm going to introduce our speaker today. Kevin Dahill has been a friend of this organization for many years. Actually, I think when Bill and I took over the operation, he was a supporter from that period of time. Kevin Dahill is the president and CEO of Suburban Hospital Alliance of New York and Nassau and Suffolk Hospital Council and Northern Metropolitan Hospital Association, and that represents about 50 hospitals and serve about 25% of the region's population. Mr. Dahill is a healthcare leader and is often sought out for his expertise on hospital economics, finance, health services, planning, and workforce issues. He has held a variety of administration positions over the 25-year period that touched upon many aspects of health and hospitals, and he was with Columbia Presbyterian Hospital at that point. Mr. Dahill is a member of the American Hospital Association's regional board and serves on several boards and task force, including the New York Organ Donor Network. Kevin, it's good to see you, and we'd like to hear from you. And I think I bill this as the stresses that are on hospitals today. And I don't know if you want to go with that theme, but probably. All right, it's all yours, Kevin.
Well, thank you, Ernie, and good morning, everyone. To say that the last 3 months have been unparalleled in the hospital industry would be probably understating things. So I thought I'd begin by just giving a summary of what the hospitals have experienced over these past 3 months, and what the status is today, and what we're going to be dealing with over the course of the next several months. So beginning in the very first several days of March is when we began to see a incremental growth in the cases of COVID-19 arriving in the emergency rooms of many of our hospitals. If you recall the media accounts, it had begun really in New York City, where we were seeing a significant increase in cases, and then spread out to Long Island and the lower Hudson Valley. March 17th, St. Patrick's Day, became a bellwether day as the volume had grown to a point where the governor began to issue what have become a myriad of executive orders. The first was declaring a public health emergency. And that was quickly followed by ordering all of the hospitals in the state to discontinue elective procedures, elective surgeries of any sort, and that resulted in the cancellation of many of scheduled cases that we had at the hospitals. He issued that executive order because the various models and projections that were coming out at that time were indicating that there was going to be an exponential growth in the cases that were going to come forward. And so...
and that was true, wasn't it, Kevin?
Well, it was true in terms of there was significant growth, but nowhere near what was in the initial models, which is good news. But for a period of time, the hospitals were stressed very significantly. Right after he issued the executive order declaring the emergency, the state activated what we call as the HERDS system, which is a software reporting system that was put in place right after 9/11. If those of us that recall the tragedy of 9/11, part of the management issue we confronted during 9/11 was our inability to track patients, where they wound up, in what emergency rooms, and so on. So this system, this HERD system, was put in place in the event of future emergencies. It was used in Hurricane Sandy, and it was activated on March 18th here in New York. What that requires, and it's still activated right now, what it requires is that on a daily basis, twice a day, all of the hospitals have to report in several pieces of data. How many patients have arrived in the emergency room? How many of them have tested positive for COVID? How many of them had to be put on ventilators and required ICU beds? So that gives the state a sort of a graphic look at what's going on around the state and where the peak volumes are and so on. as the numbers continued to grow into mid-March is when the governor really lobbied the federal government for assistance in a few different ways. One was these models were predicting that we weren't going to have sufficient capacity in the hospitals to take care of all of the cases that were coming forward. So on March 20th, he issued an executive order which required every hospital in the state to expand its capacity by 50%. And it was left up to the individual hospitals to determine how they would do that. And the contingencies that the hospitals had to put in place were highly variable depending on the hospital. Some hospitals literally.
You know, Kevin, I wanted to ask you about the prospect of, you know, we run our hospitals on the most efficient way we can. And that means that we have, you know, just enough. Now, when you have an emergency like that, that's not going to be good enough. You're going to fall behind. Is there a way to mitigate that situation?
Well, there is, but it requires some imagination, quite frankly. So what the hospitals did were two things. Within their own structures, they converted spaces into intensive care units. So because we were not going to be doing elective surgeries and procedures, we converted areas like the recovery rooms into intensive care units. And the staff that otherwise would have been involved in the elective surgeries and elective procedures were redeployed into these units to help take care of patients. Second thing was, here on Long Island, the federal government worked with us through FEMA and the Army Corps of Engineers to develop two alternative sites, one at Stony Brook and one at SUNY Old Westbury. And they literally came in and built alternative hospitals at those two sites. Each contained about 200 beds each. Fortunately, we never had to use those as time went on and the volume started to dissipate. But they were here. And in New York City, the Javits Center was converted into hospital space with ICU beds. And on the Upper West Side, the USS Comfort naval ship came into the harbor, and it contained 250 hospital beds. So excess capacity was brought in and was used at those two sites. Those two alternative sites did get activated for a period of time because the city hospitals had a lot of spillover. So we then, on a daily basis, worked with the Department of Health and literally made decisions on moving patients around. So believe it or not, there were patients being transferred from Nassau County into New York City, into these alternative care facilities. In some cases, before the Javits was ready, some of the hospitals in New York City sent patients up to hospitals in Albany so as to redeploy them. So there was a lot of command and control issues that we had to deal with. The second area of concern had to do with equipment, so-called PPE, personal protection equipment. And that's gowns and masks and gloves. And now every hospital keeps a stockpile of those kinds of equipment on a regular basis, but no one could have predicted the demand that grew given this outbreak. And so there was a mad scramble for that kind of equipment. And this is an area where going forward, we are going to have to debrief and come up with a better management system, quite frankly, for future emergencies, because it ended up that the hospitals were competing with each other to try to secure this equipment. The state
Are
was
we
out.
considering a national depot for these things so they can go wherever they are needed? So right now, the Southwest looks like it needs a lot of help. I don't know if they have a place to get it, and if they need it.
Right. So that's going to be part of the discussion that's going to have to go on. If I had a vote today, I would vote to make it a little bit more local. I would vote for a state stockpile because, given the size of New York State, given the geography, we're complicated enough unto ourselves, and to have to be hoping that the federal government could deploy this equipment all throughout the country would frighten me, to tell you the truth. So I would vote for a more local approach, but there will certainly be this discussion, and we'll have to see what happens. Ventilators, I mentioned ventilators before. Ventilators also became an issue. Again, hospitals maintain an inventory of ventilators on a regular basis, and but the demand, the need was so much more than anything we've ever seen before. And we had to move ventilators around the state. I will give the state Department of Health a lot of credit because they had that data from that herd system. They were able to literally direct that hospitals from upstate, which had much fewer cases, we're going to have to move ventilators down to downstate, and that happened. The state literally went to hospitals upstate, picked up ventilators, and brought them down to our hospitals. But that's another issue. That's another area that we're going to have to talk about going forward, should something like this present itself again. And I'd point out also that we were, early March, we were just coming out of the winter dole, season, but we had a very significant flu season this past winter, with a lot of patients admitted and put on ventilators just because of the flu. So this COVID outbreak just compounded what was already in place. It wasn't like we had a lot of capacity going in.
Do we know what the percentage of the COVID was in hospital use compared to what we would normally expect from a flu season or from this flu season?
Yes, it was significantly higher. We got to a point at the peak where patients admitted into the hospital were significant. 60 to 65% of patients in the hospitals were COVID positive patients.
Who's going to be taking up the responsibility of testing? One of the things that, a person of my age particularly, is that we're vulnerable. We're vulnerable by virtue of our age. And then we have people who are vulnerable by virtue of their health conditions. We don't have a testing system that would keep us apprised of what the dangers are. Is that going to happen?
Well, the capacity to do the testing grew significantly over the course of the last month or so. But here's the complication. Remember, I said that the hospitals had been ordered to stop all elective procedures, all elective surgeries, and so on. That took a lot of demand off of the laboratories. And so they were able to increase the COVID testing significantly. Now we have begun to resume the elective procedures and the elective surgeries and so on, which has put that pressure back on the labs for testing for those things. So it's now going to become a question of the capacity of the laboratories to turn these things around. When we do an elective surgery, say a hip replacement on a patient, we're required to run the preoperative testing no more than 3 days in advance. And now we also have to test them for COVID. And so that's putting a lot of demand on the laboratories. And we're beginning to have some issues in that regard.
Well, I don't know how people are going to feel safe in the supermarkets, in the theater, in the restaurants, until we have significant testing. And I don't see that happening.
Right. Well, you know, sooner or later, I think the laboratories are, somebody's going to have to provide incentives for these laboratories to expand their capacity to do these tests. And I think it's going to, you know, I think the demand is going to grow, and I think the outcry is going to grow, because I think you're absolutely right. We're beginning to see, now that we have returned, we've gone and reopened elective surgeries and procedures, we're seeing significant declines in volumes from previous years, which indicates to us, and it's about 50%, quite frankly, which indicates to us that patients, consumers are reluctant to come to hospitals for their care, you know, other than COVID care, because they're fearful. And it's probably because they haven't been tested, or they're just afraid to come into that environment. We're doing a lot of, you know, communications publicly, and you've probably seen television ads we're doing and whatnot to try to encourage people not to forego their care at this point. But the volume is down by about 50%.
What about burnout? I think doctors are experiencing, you know, burnout. Excuse me.
Right.
What do you know about that?
Well, it's interesting. One of the areas that has seen a lot of growth in terms of how they're using it is what we call telehealth. A lot of physicians who prior to this outbreak were not won over by telehealth and did not want to do virtual visits like we're doing here with their patients, have now come full circle and are using telehealth. And the good news is the government is requiring the insurers to pay for it in terms of visits. I think that's helped a little bit with the issue of burnout. But listen, I can't emphasize enough, it's not just physicians. Nurses, respiratory therapists were just really worked to the bone throughout these last 3 months.
I meant the entire medical profession is affected.
Yeah. So, you know, I think that now that the numbers have come down somewhat, and we've redeployed staff back to the recovery rooms and so on, that's allowed for a little bit of a decompression. But yes, they all went through a very rough period of time.
You want to take questions from other people?
Sure. I think I see Ken there has a question.
Yeah. Can you activate Ken?
I've asked him to unmute.
Hey, good morning, Kevin. How are you?
Good, Ken. How are you?
Yeah, with such an illustrious career and, you know, working 24 hours a day, what are you going to do now that you're retiring?
Good question. This is one hell of a year to go out on, huh? I'm going to figure something out. I enjoy teaching, so I hope to do a little bit of that. And I'll figure out. I'll keep myself busy. That's for sure.
Yeah. When is your date for retirement?
The end of the year, December 31st.
Oh, good. Well, good luck.
Thank you. Thanks, Ken.
You certainly had a varied career. You did a lot of different things in your career. You certainly have probably a lot of places you could spend your time.
Yeah, I've been very fortunate. The healthcare industry, particularly the hospital, have been very good to me, and I've enjoyed all those experiences I've had. So yes, I think I enjoy teaching. I enjoy public policy. So I'll figure something out.
Now, in your position, are you in competition with any other units, or are you're kind of encompassing all of the health industry?
Well, I covered the two regions, Long Island and the lower and mid Hudson Valley. So I represent about 25% of the hospitals in New York State. There's the Greater New York Hospital Association in New York City, who represents the New York City hospitals. And then upstate, there are regional associations as well. I would say that 90% of the time, we are all on the same page in terms of our priorities, but there are at times going to be issues that are unique to a suburban region like ours, and then I'm sort of on my own representing those hospitals' issues.
What are the most challenging things you've done in recent years?
Well, I would say prior to this, Hurricane Sandy was a significant challenge. Obviously, a public health emergency of a different sort, but
why was that a health emergency, Kevin?
Because a lot of our hospitals had to be evacuated.
Oh, you lost a lot of facilities, you mean?
Well, for a period of time, we lost one totally, Long Beach Medical Center, but we had to evacuate several others and evacuate those patients into the other hospitals. That was quite a significant challenge.
Hmm. Did that result in the loss of life, or you can't measure that?
It's hard to measure it because patients, some of those patients who got moved eventually might have died, but we don't know if it was a cause and effect or it would have happened otherwise.
Yeah. So, do you know who is going to be replacing you?
No, the boards have put a search committee together, and they're commencing a search. So I would imagine it's going to be another month or so before we'll know.
Yeah. Because the breadth of your experience would make it hard for you to be replaced, I think.
There'll be somebody out there. No, yeah, there's plenty of talented people.
Well, I agree. None of us are. Who said that the graveyards are filled with indispensable people? But
Right.
but you're not going to the graveyard.
No, hopefully not. Hopefully not.
Not yet.
Right.
So, anybody else out there with questions? Yeah, anybody who needs to raise your hand, use Alt-Y on your keyboard. All right. Who has a question?
I do.
Oh, go ahead.
Hello, good morning, everyone. Sorry, I'm a little late coming in to the meeting. I had a question regarding community health workers. It's actually a program that I am aware of that is at Nassau Community College. And I wanted to see what your thoughts are on that role in the hospitals.
Right, thank you for that question. An area that has been developed that is going to require a significant number of personnel is in the area of what is being called contact tracing. And what that's all about is, as we do the testing of patients, those that test positive are going to be followed by community contact tracers to determine who else they've been in contact with, where they might have picked up the virus, and ensuring that they quarantine themselves for a period of time. So the county departments of health, so in our case, Nassau and Suffolk departments of health, are required by the state to hire a specific number of these community workers to be available for this contact tracing program.
Does that raise any questions on privacy and things like that? And have you addressed them?
It does raise questions on privacy. Some of the what would normally be regulations get waived when a public health is declared by a governor. So in this case, the hospitals are required, and the laboratories are required to report to the Department of Health those individuals that have tested positive. And under normal circumstances, we'd say, boy, that sounds like an invasion of that person's privacy. But in a public health emergency like this, with the contagious nature of this kind of virus, that's the way it is. And that's the way we're going to be functioning for the probably next year or so.
Do these people have to be specially trained, or is it just a sheet with questions on it that?
Yeah, they get some level of training. It's not terribly comprehensive, but there are certain regulations that they have to abide by that are not waived, and they get trained on that. The kinds of individuals that are being recruited are nursing students, social work students, those kinds of people who already have an interest in doing this kind of community health work.
I was thinking that just like we had the Vista course and we had the Peace Corps, this would be a good place for those people to come into the picture.
Yeah.
These are resources.
Yeah, absolutely.
Not only that, I have a belief that everybody should be in some kind of service to their country, whether it be military or some other capacity, just because of the experience that I had when I was in the military. I got to meet people from all over the country. You get to understand people more. And I don't think we have that cohesiveness in the younger people because they haven't had that same experience. I do agree that college is part of that, but not everybody goes to college.
Right. No, I think, in a crazy sort of way, this opens up an opportunity for individuals to have a new life's experience.
Be part of a country.
Yeah.
Because, this is a great country, and I treasure the time I spent with the U.S. Coast Guard. I think that was one of the nicest. I didn't think so at the time, but in looking back,
Right.
It was a great experience.
We
They're
have,
actually-
we have Harvey has not technically raised his hand, but he did indicate that he has a question. Harvey, I'm going to allow you to unmute now. You should have that ability to turn your mic on and ask your question.
Harvey, you have to unmute.
He's not done that. I could see his lips moving, but he didn't unmute. The lower left of your screen, there should be a microphone to unmute. You have to click it.
Can I do it for him?
No. I'm afraid Harvey's, again, I can see his lips moving, but we're not hearing him. So we can't ask your question. If you'd like, Harvey, you figured out how to chat earlier. If you'd like to type it in, I could read it to the group, or you have to figure out how to, again, it's a microphone in your lower left. And while we have this pause, while Harvey looks for that microphone in his lower left there, I want to point out that we have a few people who have called in on their telephone. And there is a way, if you have a question on your telephone, if you press *3 on your telephone, that will raise your hand so that we know you have a question.
And we have Robert Doyle. I think he's looking to make a question too.
Okay, why don't we move ahead to Robert?
Robert, you have to unmute.
Okay, Robert should be able to unmute.
I
think
you had it, and then you got lost it, Bob.
Let me try it again. There we go.
Morning. Yeah, I do not have a question. I'm good, Harv.
Oh.
I'm good. I'm enjoying the conversation.
Do you think you can help Harvey unmute?
Yeah, you're right next to him. Just give him a shove.
Harvey's having a whole conversation with himself over there. Okay. All right. While we're on the, does anyone else have any questions? What I might do is oh wait, here we go. We have a comment coming from Annette Krause. I guess I muted her, so I'm going to go ahead and read this. There are actually two positions separate from one another: a community health worker and a contact tracers. Contact tracers receive 5 hours of training. Community health workers help people in lower income communities to help them maintain their health and advise them in finding resources available to help them. What I was wondering is how they see community health workers evolve in hospitals. And Annette, I'm going to go ahead and unmute you now, or allow you to unmute yourself if you have a follow-up to that question.
That's really my question, is particularly community health workers, how you see it, that position evolving in hospitals, because it's really just kind of starting, I guess, in the healthcare industry. This extra program that Nassau Community College offers, and I know people that just graduate actually from this program, and I wanted to see what your thoughts are on how it will be an integral part, or how it will evolve in hospitals, in healthcare.
Harvey, you have to adjust your screen so you can see the mute button. I don't know how you do that, but
well, is there an answer to Annette's question before we go back to Harvey and his technical problems? Did that require an answer? Kevin?
Kevin is muted for some reason.
Oh.
Kevin, can you unmute yourself? There you go.
Okay. No, yeah, it was telling me I had to be unmuted by the host.
I'm sorry. I think I might have done that wrong person.
Okay.
Sorry, though. Go ahead, Kevin.
Yeah, in response to Annette's question, Annette, you're absolutely right. The community health workers that you're talking about, the hospitals are just beginning to think about what we call population health, and that is looking at issues out in the community that are affecting the health of individuals. And I expect this to become more and more of a priority going forward. One of the things we have found in this COVID experience is that areas of greatest need, socioeconomic need, are where the population was disproportionately hit by COVID. So issues like housing, food, transportation, those are all areas that are going to require more attention going forward. And so the utilization of community health workers to do outreach is going to be more and more significant. So more of that to come once we get through this recovery period.
I think I unmuted.
Yes,
Yes, you're with us.
yes, it may have been partly my fault. I apologize, but I think we've worked it out.
Okay, thank you, Marguerite. So Kevin, I wanted to go back to the PPE situation that you were referring to earlier. And I'm putting the ventilators into that group of PPE equipment. There was a tremendous assumed need for ventilators in New York by the governor. Thank God it didn't turn out to be the number. But is it fair or reasonable or practical to expect 50 states to stockpile something like ventilators to the point where in the event of something like a pandemic, they would need that quantity, where the rest of the time it would just be sitting idle? Or does it make more sense for like FEMA to stockpile and then disperse them to the states as needed? I mean, it's just so confusing, all of this controversy over states competing with states and hospitals competing with hospitals to get these ventilators and paying a premium for them, including the PPE equipment, which, just didn't seem to make sense to me going through this whole pandemic and going through it. We're, as so many people say, we're barely in the second inning of it.
Right.
So
ventilators are very expensive pieces of equipment. And I think there is an argument to be made on ventilators for a national stockpile of that kind of equipment. That's not to say hospitals wouldn't maintain an inventory, a regular inventory on their own, but for outbreaks such as the one we're going through, there is an argument to be made for the national stockpile. Where I come down on the side of being more local is on PPE, personal protective equipment, gowns, masks, gloves, goggles, those kinds of things. I think I would argue probably a stockpile on a state level makes a lot more sense, because it could be more readily available and so on. The other is, I think we need to be producing more of this equipment here in the United States.
Amen.
As opposed to, I can't tell you, Harvey, how many calls I received over the course of the first 2 months of this thing from people, including elected officials, who call me to say, I know a guy who knows a guy in China who can get you X amount of gowns within a week. And some of the prices that were being quoted were atrocious. So that's another conversation that has to go on at the right time here.
Thank you.
Sure.
Well, this is Frank Burjo. I'm from Desktop Solutions. I'm the administrator of the meeting. I have a question, and it's about this controversy of sending patients to nursing homes. I have a personal stake. My mom actually got sent to the hospital and then transferred in the middle of the crisis, and now I've discovered that it's a controversial move, and I'm wondering what your opinion was about that.
Yeah, I think that in hindsight, as I said earlier, the governor's office put out a myriad of executive orders um, in an attempt to manage this whole emergency. And one of those executive orders came on March 25th when he ordered that nursing homes had to accept patients being transferred from the hospitals. And as I mentioned earlier, on a daily basis, the State Department of Health literally oversaw the transfer of patients from facilities to facilities. We thought that it would have been much more appropriate to transfer patients to these alternative care facilities that I talked about, because nursing homes can be a breeding ground for a contagious virus like this. But nevertheless, the state took the position that it took, and we were bound by it. Now, the reverse has happened. Now, the governor has ordered that nursing homes have to provide tests for their staff twice. Well, at first it said twice a week. Now it's once a week. And we're finding that the nursing homes have been put in a position where they're having difficulty accepting any patients, any new transfers, because they can't get their staff tested. So, it's not a cop-out, but when we're dealing with an emergency declaration like this, and we get besieged with executive orders, we have to follow them. And it's just the way it is.
But you began by saying in hindsight, and I guess that's the thing, is that to me, when my mother's 93, and I think that would be typical of a lot of the population that we're talking about. Mm-hmm. She wouldn't have been a candidate for moving to a SHIP facility or one of these temporary tent facilities. That would have been the option at that time?
Well, in my opinion, if those facilities were just taking care of patients who were not testing positive for COVID, then I would consider that a safer environment. Might not be the most comfortable, or it might pose logistical problems for families having to get there to see them and whatever. But rather than have a facility where half the facility is full of patients with COVID and half not without, I'd say a safer environment is one that doesn't have exposure to COVID.
Yeah, I remember that controversy as well with the comfort, whether or not it would be used for infected patients or non-infected. But I think circling back to something you said earlier, all of this needs to become a teachable moment so that there are procedures and some decisions made in advance, because hindsight's 20/20.
Right, absolutely. And we haven't dealt with anything like this before. I talked about Hurricane Sandy and what a challenge that was, but we learned things there too that we changed for going forward. But the nature of this, a pandemic with a contagion level unlike anything we've ever seen before, and the demands that it put on the system, ventilators, intensive care unit beds, all of that. Yes, we have a lot of debriefing to do now that we're on the decline.
In a similar way, before I thought of the nursing home question, I was going to mention my wife is in the medical field, and they had no plan in their, and it's not a small office, she works at Northwell. They had no plan for who's going to work virtually, who's going to work in the office, how many shifts. They had to make all that up as they go. it seems to be another thing, and I would think that should be not just left up to each individual office manager, but to be really mandated and coordinated, so that the same way that large buildings have to have an emergency plan in place, that these healthcare facilities have a virtual plan in place, so people know and expect and have the facilities at home and aren't left, scrambling as we did this time around.
Kevin, I wanted to ask you about universal health care, which we do not have, but would it have made a difference if we did?
I don't think so, because this ended up not being a payment issue. If anything, the federal government mandated that testing and even the care of COVID patients be covered. No, I don't think so. Economically, the financial stress now that has been put on the hospitals is due at this point, to the fact that we had to close down all the elective procedures and services. So, that would have happened either way, and that same stress would exist. I will tell you though, that, I was getting calls from all sorts of individuals who wanted to find a way to help. Community organizations, particularly, never once heard from any one of the insurers. And, you've got to imagine that the insurers financially have thrived through this because of all of the procedures that haven't been done. And that's money they keep in their pockets. But never once did I hear from any one of the insurers to say, what could we do to help?
These outside groups that volunteered to help, were they a significant help for you, or are they peripheral?
Some more than others. A major concern that we had was we had to not allow visitation for almost 3 months. So families weren't allowed in to see their loved ones in the institution. We had some community agencies step up and do things like FaceTime, met with the families outside the building, hooked them up electronically so they could talk with family, those kinds of things, and as you said earlier, really doing a community service, when families were very stressed. So, nice things like that happen.
We're getting ready to wrap up, but I want to see if there's any other questions out there. Do we have anybody who wants to make a statement or ask a question?
Once again, raise your hand. You could use the Alt-Y or Option-Y on your keyboard, or if you're on the phone, you would press *3. Doesn't seem like we have anyone else.
Okay. If that's it, we'll wrap. We're into the hour. I want to
Ernie, I have a quick question for Kevin, if I could.
Sure, go ahead.
Yeah, Kevin, thanks for your presentation. The hospitals that you represent, it seems like there's such a large number and there's such a large part of the regional economy. And you said, I think that you're at about 50% capacity, ramping back up with elective procedures. Looking into your crystal ball, how long do you think it will take to get to 75% or beyond and get the hospitals up and humming again, near full capacity? Not before the end of the year, not into next year, or what do you think?
It is a crystal ball question. My guess is that people are going to hedge their bets through this summer. And wait and see whether there's this second wave that gets talked about. If that doesn't happen in any meaningful way, that is a second wave, and there's hopes of a vaccine by early next year, my guess would be that's when, by early next year, that's when we would see a return to some level of normalcy. I'd be surprised if it's before that.
Well, that poses another question for me, Kevin. The money lost is lost forever, I would think. Is that true?
Yes, it is. The federal government has stepped up when they passed the CARES Act, the stimulus bill. They did infuse some dollars into the hospitals around the country.
But that's not going to make up the difference.
But that's nowhere near going to make up the difference. Here's an interesting number. The American Hospital Association has calculated that just in these last 3 months, hospitals throughout the country have lost about $210 billion.
Wow.
That's incredible.
Good number.
Do you have a follow-up on that, Robert?
I'm not surprised to hear Kevin's response. It's a little bit disconcerting. I will say that in my law firm, I know that more than several of our employees have gone back for some type of medical care since the offices and hospitals have opened up, and people have come back with good stories about the procedures in place and how safe they felt, and having waiting rooms in the parking lot and how efficiently it worked. And I myself went back for blood work and just some routine care, and I felt safe, and I felt like there were procedures in place and that the staff was very much accounting for the overall health of everybody who came to the office. So but it's important. I'd like to hear that things were getting back to normal before, March of next year. But that seems to be what many businesses and many industries are saying.
Bob, I had a very similar experience recently, and you do feel a lot safer. Well, I think we're going to wrap, and I want to thank you, Kevin, very much for making yourself available. Our next program was going to be with Joe Campola. Joe is a very bright and concerned citizen of this region. And I read his stuff all the time, and I asked him to get into a conversation with me. It'll be broad, it'll be encompassing, and I think it'll be interesting as it was today. So I want to thank our sponsors, the Gershow Company, Toomey Latham, Lewis Joes, and Covanta, and our daily program, Public Relations Marketing Group. I want to thank everybody who came into the picture, and literally, and I wish you all a very good day, and we'll look forward to you. Now, the next program is on the 16th. Of the 10th, wait a minute, it's the 10th of July, and 10th of July, same time, and I look forward to hearing from all of you. All right, thanks again.
Thank you, everyone.
Bye, everyone. Thank you.
Thank you, Ernie.
Bye.
Thanks, Kevin.
All right, be well.